Welcome to the class. So our topic of discussion is obstetric pelvic floor and the anal sphincter injuries. So this is the talk on the obstetric pelvic floor and the anal sphincter injuries. Okay. Now, if you see in this figure, they have given the classification of the perineal trauma. So if you see this particular box, it is divided into classification of the anal sphincter tears proposed by Thacker and Sultan. Okay, it is a first degree when there is a laceration of the vaginal epithelium or the perineal skin only. So if it is only vaginal mucosa or the vaginal epithelium or the perineal skin, it is a first degree. In second degree, there is an involvement of the perineal muscles, but not the anal sphincter. So perineal muscles are involved, but the sphincter is not involved. In the third degree, there will be disruption of the anal sphincter muscles, which should be further divided into 3A, 3B, and 3C. And here are the SBA questions. Okay, they will give that the anal sphincter is injured up to 50%. There is the damage of the anal sphincter, 50% damage. Where will you include? Okay, external anal sphincter is 50% damage. So you have to include it into 3B, because here they have not given equal to, whether equal to is here or whether equal to is here. Now it should be included in 3B, because in we will subsequently see in the guideline, when there is a doubt, you have to give the higher degree. Okay, you should never underestimate the damage. You should always overestimate the damage and correct it. Okay, so it will be 3B if it is a 50% damage. Then 3C, when the internal sphincter is also torn. So when there is an external sphincter which is less than 50%, 3A. External sphincter more than 50%, it is 3B. And if internal sphincter along with external is gone, then it is a 3C. And a fourth degree, when third degree tear with disruption of the anal epithelium. So if the anal mucosa is also involved, then it is a fourth degree. So these are the degrees of perineal tears. Okay, and here you see the anatomy. Here you see the internal anal sphincter. Here you see the external anal sphincter, which has got a superficial, and this is the superficial part, and these are the deep parts of the what you can say, the external anal sphincter. And these are the degrees 3A, where this external anal sphincter is up to 50%, 3B when it is more than 50%, 3C when there is an internal sphincter is also torn. Okay, here you see this is the internal sphincter, this is the external sphincter, and internal sphincter is involved, it is 3C. And when the anal epithelium is also involved, it is fourth degree. Is it clear to you?
Yes,
Yeah.
sir. Yes, sir.
So the pelvic floor mainly consists of the musculo-tendinous sheet called the levator ani muscle. Levator ani is subdivided into iliococcygeus, pubococcygeus, and ischio-coccygeus. The pubococcygeus is further subdivided into pubourethralis, pubovaginalis, and puborectalis. Okay. Then puborectalis is the most caudal component of the levator ani complex and is situated cephalad to the deep component of the external anal sphincter, from which it is almost inseparable. So it is the puborectalis that is the most caudal component of the levator ani complex, and it is situated cephalad to the deep component of the external anal sphincter, from which you cannot separate it. The puborectalis therefore participates in the sphincter mechanism. Between the two arms of the puborectalis lies the levator hiatus, through which the rectum, vagina, and urethra pass. The innervation of the pelvic floor is via the sacral nerves S2 to S4, and it is believed that some innervation also occurs via the pudendal nerve. Okay. Then perineum, we have already seen perineum corresponds to the pelvic outlet and is bound anteriorly by the pubic arch, posteriorly by the coccyx, and laterally by the ischiopubic rami, ischial tuberosities, and sacrotuberous ligament. The perineum can be subdivided into two triangular parts by drawing arbitrary line transversely between the ischial tuberosities. Okay, the anterior triangle is also called as urogenital triangle, which contains the superficial muscles, which include the superficial transverse perineum, bulbous spongiosum, and ischiocavernosus muscle. The posterior triangle is the anal triangle. It contains the anal sphincter complex. Okay. Now, what is the prevalence of these tears? Remember these particular figures frequently asked in the examination. About 8 out of 10 women in the UK sustain some form of perineal trauma during the childbirth. How many women? 80% women will have some form of perineal trauma. Okay, overall noticeable increase. These are not all third degree and fourth degree. This some kind of trauma is always there in 80% of women. Now, overall noticeable increase in the prevalence of OASIS, that is obstetric anal sphincter injuries. Okay, attributed to improvements in the detection of such injuries. So the increase incidence is mainly because of the improvements in the detection of such injuries. Okay, episiotomy rate in the UK is around 8 to 16% compared to 52 to 82% in the European countries and 39% in the USA, because they practice selective episiotomy. Okay, they don't give routine episiotomy, they give a selective episiotomy. Okay, that is why episiotomy rate is 8 to 16%. The prevalence of third and fourth degree perineal tears, collectively referred to as obstetric anal sphincter injuries, that is OASIS, is dependent on the type of episiotomy practice. Remember, it is a type of episiotomy which is practiced decides the prevalence of the third and fourth degree perineal tears. Okay, in centers where mediolateral episiotomies are practiced, the rate of OASIS is around 1.7% and 2.9% in the primaries. So 1.7 and 2.9 in the primaries compared to 12% and 19% in primary in centers where midline episiotomy. So if you give midline episiotomy, there is a high incidence of these perineal third and fourth degree perineal tip. Midline episiotomy 12% overall, and in primaries almost 1 in 5. 19 means 20%. Every fifth lady will have a perineal tear. Okay, if the midline episiotomy is practiced, while if you practice mediolateral, there is a very less, hardly 1.7% is incidence of obstetric anal sphincter injuries. Okay, recent 2010-11 survey of maternity units in the United Kingdom has revealed an OASIS rate of 3%, range is around 0 to 8%. Okay, and around 2.1% in primary. So overall incidence is around 3%. Okay, it varies actually from 3 to 8%. The green top guideline will give you the figure of around 3 to 8%. Okay, and it depends upon the type of episiotomy which is practiced. Okay, now pelvic floor dysfunction following childbirth. We have just seen the anatomy of the pelvic floor. Now what happens during the childbirth and what dysfunction gets developed. So there can be anal incontinence, there can be urinary incontinence, there can be pelvic organ prolapse and sexual dysfunction. All these may be in the immediate period or may be happening over a period of time also. Okay, what are the risk factors? One is the increased body mass index. Second is a large fetal head. Third is a forceps delivery. Fifth, another is a first vaginal delivery have been implicated in the development of pelvic floor dysfunction. That is the primary gravidas. Okay, first vaginal delivery. Okay, increased body mass index, large fetal head, forceps delivery, and the primary gravidas. Remember here, the primary gravida is the highest or the most important risk factor. So even if all these four factors are given, it has been observed that these injuries are more common in the primaries. Okay, so among those who deliver exclusively by cesarean section, 40% still report urinary incontinence, and cesarean section confirms no benefit in terms of subsequent fecal incontinence. Okay, so even if the patient is delivered by the cesarean section, then also the urinary incontinence can develop. Okay, and even for fecal incontinence, cesarean section does not have a protective benefit. Okay, it would therefore appear that the pregnancy itself rather than mode of delivery alone may be a contributory factor in the development of pelvic floor dysfunction. So it is only the gravid status that itself is contributory than the mode of delivery, because even the cesarean section does not have a protective role. Okay, now coming to the anal incontinence, what we have seen, total four dysfunctions we have seen. One, it can be anal incontinence. Second, it can be urinary incontinence. Third, it can be pelvic organ prolapse. And fourth, there can be sexual dysfunction. So coming to the anal incontinence, the WHO International Consultation on Incontinence defines anal incontinence as the involuntary loss of flatus, liquid or solid stool that is social or hygienic problem. Okay, so it is a social and hygienic problem, and there is an involuntary loss of flatus, liquid or solid stool. Now, what is the mechanism? There can be direct mechanical injury or there can be pudendal neuropathy. Okay, so direct mechanical injury, the process of continence and the defecation are complex. Direct mechanical injury to the external anal sphincter and or internal anal sphincter resulting from obstetric trauma is a major cause of anal incontinence. So there is either damage to the external or internal or both by the direct mechanical injury will lead to anal incontinence. Second is a pudendal neuropathy. It may be result of nerve compression from the fetal head, fetal macrosomia, prolonged pushing during the second stage of labor or forceps delivery. That all can lead to the pudendal neuropathy. Then pudendal is particularly susceptible to compression and damage at the point where it curves around the ischial spine and enters the pudendal canal enclosed in its tight fibrous sheath, that is Alcoxan canal. So this is also SBA. The pudendal nerve is at risk of damage at such and such place. So it is susceptible to compression and damage at a point where it curves around the ischial spine and enters the pudendal canal enclosed in its fibrous sheath, that is the Alcox canal. Okay, stretched or compressed nerves often undergo demyelination but usually recover with time or reinnervation of the muscle occurs. Okay, combined mechanical or neurological trauma. So there can be direct injury, there can be neuro, and there can be combined. Okay, isolated neurological injury as above is believed to be rare, so they go hand in hand. There are other mechanisms also. Additional factors also play in role in maintaining anal continence, namely normal consistency of the stool, normal bowel transit, rectal insensitivity, functional rectal reservoir, and intact somatic and autonomic innervation. Despite primary repair, the anal incontinence occurs in 39% of patients. So even if you do the primary repair, still there can be incontinence. This may be indicative of inappropriate diagnosis or inadequate repair technique. Okay, flatus and liquid fecal incontinence were more common among women who had sustained oasis, and symptoms were most severe after internal anal sphincter injury. So flatus and liquid fecal incontinence were more common among women who sustained oasis and especially after internal anal sphincter injury. Okay, risk factors. The first vaginal delivery confers the greatest risk of sustaining oasis. Okay, so primary gravidas are at high risk, with new injuries occurring up to 10 times more commonly in primiparous women. Okay, now the prevalence of fecal incontinence is predominantly associated with forceps delivery, unassisted delivery at home, large fetal head circumference, obesity, increasing maternal age. So these are other associated factors. Then midline episiotomy, first vaginal delivery, shoulder dystocia, persistent occipital position have been identified as the main risk factors for the development of the obstetric anal sphincter injuries. Now, can the cesarean section reduce the risk of anal incontinence? No. No significant difference in the anal incontinence was seen in randomized control trial. We will not go into the details, but just remember the cesarean section is not protective against the anal incontinence. Okay, now what is the role of imaging? What you have to do? You have to do endo-anal ultrasound. It is highly detailed images of the sphincter. You can see the external anal sphincter, you can see the internal anal sphincter, you can see the defect. Okay, imaging has become essential in the assessment and management of fecal incontinence, particularly related to obstetric trauma. So endo-anal ultrasound, you will have the figures, this such kind of figure you will see mm, here. Here it is the this is the endo-anal probe. Here the probe is inserted. Okay, then here you see is the external anal sphincter, here is the internal anal sphincter. Okay, so here is the internal anal sphincter and this is the external anal sphincter. Now you see this internal anal sphincter, here there is a damage. Okay, you see this external anal sphincter, here there is a injury. Okay, so in the figure B you can see defects in the internal anal sphincter between the white arrows. Okay, between the white arrows there is a injury to the internal anal sphincter. Okay, and external sphincter between the black arrows, this is the external anal sphincter after inadequate fourth degree tear repair. So this is after the repair. So when you ask these patients for follow-up, you have to do these investigations and find out is there any defect or not. Okay. Now, sexual dysfunction, that is another dysfunction of the pelvic floor. What we have seen up till now is the anal incontinence. Now, sexual dysfunction. Sexual health problems are common after childbirth, however, frequently underreported. And the reasons are, one is the embarrassment, and second is a preoccupation with the newborn care. So, female will always be occupied with the newborn. So, these issues are neglected. Some of the reasons why women do not seek help. Most common sexual disorder is a sexual pain followed by disorders of sexual desire, arousal, and orgasm. So this is in the puerperial period. Okay, pain, sexual pain is a common in the puerperial period. Okay, in other reproductive period, the problems are different. Okay, incidence, perineal pain is seen in 42% of women immediately after delivery and reduces to 22%. That is almost 50% reduction you see at 8 weeks, and it will come back to 10% at 12 weeks. Remember, 40%, 20%, and 10%. Roughly, you remember immediately, then at 8 weeks and at 12 weeks. That means initial there is a 50% reduction, then there is additional 50%, that is 25%, 40, 20, and 10%. Okay. Then again, these figures will not be asked, so we will skip this particular slide. Okay. What are the risk factors? In a prospective study, Barnett et al. Found that dyspareunia in the first 3 months after the delivery was significantly associated with vaginal delivery and a previous experience of dyspareunia. So, in the first 3 months after the delivery, if it is a vaginal delivery and if the patient has got a previous dyspareunia, already had a dyspareunia, there is a high chance of dyspareunia in the first 3 months after the delivery. However, at 6 months, okay, there was no association between the dyspareunia and mode of delivery, but previous experience of the dyspareunia remain a significant risk factor. So the mode of delivery does not have effect by around 6 months. Up to 3 months, definitely the vaginal delivery, there will be dyspareunia, but around 6 months there is no association with the mode of delivery. However, previous dyspareunia, these patients will continue to have a dyspareunia. Okay. Now coming to the third problem, that is a pelvic organ prolapse. Okay, mechanism is a levator ani muscle injury that may be partial or complete. Okay, it is found in vaginally parous women, increases the chance of a woman developing pelvic organ prolapse by 4 to 11 times. Okay, so if there is a vaginal delivery in parous women, then the chance of pelvic organ prolapse is high. Okay, levator avulsion injuries or denervation injury occurs during the descent of the fetal head and maternal expressive efforts during the active second stage of labor and crowning. Consequently, the levator hiatus enlarges and leads to anterior and central compartment prolapse. So where do you get prolapse is the anterior and central compartment, and this happens during the maternal expulsive forces during the active second stage and during the descent of the fetal head. Okay, so here you can see the three-dimensional endovaginal ultrasound, and you see this is the hiatus, which is normal. Okay, normal levator dimensions, this is the normal. Here you see that the enlarged levator hiatus. Okay, following the pelvic organ prolapse. Okay, and in image see levator avulsion. So levator avulsion on the left side. So you see here the levator avulsion. Okay, so these are the injuries which can happen and can lead to the prolapse. So what is the incidence? Prolapse is common in women after vaginal delivery. 50% of parous women will have some degree of pelvic organ prolapse, of whom 15% will be symptomatic. Okay, so parous women, POP will be seen in 50% of patients, but 15% will be symptomatic, while only 2% nulliparous women will be symptomatic. Okay, the risk factors are pregnancy and the vaginal delivery. Hormonal and mechanical effects can be there. Then pelvic denervation and the reinnervation are associated with the stress incontinence and POP. So these are the things. Hormonal effect is there, mechanical effect is there, the pregnancy itself and the vaginal delivery through the hormonal effects basically, and the pelvic denervation can lead to these particular prolapse. Okay, now coming to the imaging, what kind of imaging is required? You can do the translabial or transperineal ultrasound. It allows the definition of the presence of pelvic organ prolapse by demonstrating descent of the vaginal wall sonographically. Vaginal childbirth results in 28% enlargement of the levator hiatus after levator avulsion compared with 6% hiatus enlargement without avulsion. So we have seen in the previous slide, there is an enlargement of the levator hiatus, and this enlargement is seen more common when there is a avulsion injury. Okay, so with avulsion injury, there is a 28% enlargement of the levator hiatus, while 6% hiatus enlargement without avulsion injury. So enlarged hiatus is found in women who have clinically significant pelvic organ prolapse. Okay, then what you can do, you can further do the MRI study that has shown that 20% primes women had a visible defect in the pubovisceral or ileococcygeal portion of the levator and MSL. These defects were not seen in nulliparous women. The most common morphological abnormality of the levator ani is described as avulsion injury in the pubovisceral muscle from the pubic ramus. This has been described in 1/3 of women, appears to be related to the childhood. Just remember that there can be avulsion injury of the levator ani, and especially pubovisceral muscle. Okay. Now, last is a urinary incontinence. Now, why does the urinary incontinence exactly not known, but most probably it is a multifactorial. There are dual mechanism of nerve and tissue involvement. Incidence is compared with nulliparous women. New urinary incontinence is more common in parous women. Okay. Lower incidence after planned cesarean section has been shown in randomized trial. Okay. Now, what are the risk factors? Contribution of the obstetric factors to the development of SUI is conflicting, and it is debatable whether pregnancy or delivery is the major contributor to postpartum incontinence. So what contributes more, whether it is pregnancy or delivery, that is debatable. Pregnancy itself rather than delivery may also be an important causal factor in the development of urinary incontinence. Postpartum urinary incontinence was independently associated with incontinence prior to and during the pregnancy, even among those having a cesarean section. Okay, so even if the patient had a cesarean section, but they previously had incontinence during the pregnancy or before pregnancy, they might continue to have the incontinence. Can cesarean section reduce the risk of urinary incontinence? In a 12-year follow-up study, MacArthur et al. Found that adjustment for the parity, body mass index, and age at first birth, women who delivered exclusively by cesarean section were less likely to have urinary incontinence than those who only had a spontaneous vaginal birth, but not if they had a combination of cesarean section and spontaneous vaginal birth. Okay, so if there is a previous vaginal delivery and then there is a cesarean section, this effect is not seen. Okay. Then what is the role of imaging? Ultrasound imaging is increasingly being used to study the bladder and urethral anatomy. Three-dimensional imaging after vaginal delivery shows enlarged levator hiatus, reduction in the urethral sphincter volume, and increased bladder neck mobility both in antenatal and postpartum period. Other ultrasound studies have shown the bladder neck is lower after vaginal delivery as compared with nulligrade controls and women delivered by elective cesarean section. Okay, now this is what is the flow chart for management after obstetric anal sphincter injury. You have to ask these patients to come for follow-up in the perineal clinic. There is a special clinic of called as perineal clinic. Okay, so then you have to do the anal manometry and ultrasound of these patients. Now this anal ultrasound and manometry may be normal or it may be normal. If it is normal and the patient is asymptomatic, the patient can have further vaginal delivery in the next pregnancy. Okay, is it clear? You will ask these patients to have a follow-up at around 6 to 8 weeks after the delivery. You will do the anal manometry and ultrasound. If it is normal, patient is asymptomatic, they can have vaginal delivery. However, if anal manometry and ultrasound is abnormal or the patient is asymptomatic, okay, then by fecal incontinence, in that particular case, if the family is complete, then you go for secondary sphincter repair. Okay, and if there is a minor patient is symptomatic but there is a minor incontinence, there is a flatus, a staining, you follow the conservative management give dietary advice, regulate bowel action, constipating agents, codeine, phosphate, and loperamide, etc. Okay, pelvic floor exercise and biofeedback, and offer cesarean section. So if the patient has got incontinence, then you will advise cesarean section. However, patient is asymptomatic and there are no ultrasound or anal manometry is also normal, patient can have a subsequent vaginal delivery. While symptomatic patients will have a cesarean section. Okay. However, if the patient does not have a desire, then you go for secondary sphincter repair also. Okay. Family is not complete, but there is a fecal incontinence. There are very few patients who will opt for vaginal delivery, but main is a cesarean section. Okay. Women who sustain obstetric anal sphincter injury with subsequent severe incontinence should be offered secondary sphincter repair, provided there is an external anal sphincter defect and there is evidence of contractility in the residual muscle. Okay, so you offer them secondary sphincter repair. Okay, some women with fecal incontinence may choose to complete their family before embarking on the anal sphincter surgery. Following counseling, these women are allowed a vaginal delivery as the risk of further damage is minimal and should not impact on the outcome of surgery. This benefit should be weighed against the risk associated with the cesarean section for all subsequent pregnancies. Okay, here there is a little controversy. You will find that they say that patient, even if is symptomatic, can have a vaginal delivery and then go for a secondary sphincter repair, while symptomatic patients ideally should undergo cesarean section. But few patients who want to, because there can be further risk of recurrence also. Okay, but this is only in selected patients and after counseling the patient, not routinely. While the cesarean section is the offered treatment to these patients if they are symptomatic. Okay, but it may happen that you repair them and advise them cesarean section, but in vaginal delivery there is a chance of recurrence. Okay, so they may prefer that, okay, we can have one more vaginal delivery and then they go for secondary repair. Okay, but this is after the counseling and not routine. Okay, so who should look after these women? The first thing, they are seen in the perineal clinic, and team of healthcare providers with the knowledge and expertise to care these women should be available to mothers. Experienced professionals such as urogynecologists, trained nurses, midwives who are trained in the anal manometry and endoanal ultrasound scanning form an integral part of the clinic. We have already discussed these two investigations you have to do. Integration of MDT, that is multidisciplinary professionals such as physiotherapists, continence nurse specialists, colorectal nurse specialists, colorectal surgeons, psychosexual counselors promote a holistic approach to pelvic floor and perineal problems. Sustain a third or fourth degree tear, and little women with any of these problems, including female genital mutilation, are also being seen in the perineal clinic. So this perineal clinic is meant for third degree tear, fourth degree tear patients and antenatal women with these problems, including the FGM, female genital mutilation. Okay, as these problems are usually of sensitive nature, women should ideally be seen in a dedicated perineal clinic instead of busy general clinic approximately 6 to 8 weeks after the delivery. This is also a question. When will you call for follow-up? You will call these people for follow-up at around 6 to 8 weeks after the repair in the following the delivery. A dedicated one-stop perineal clinic provides women with an opportunity to be given an explanation of circumstances under which the perineal injury occurred and appropriate counseling regarding mode of subsequent. So you have to talk to these patients, why this has happened, what exactly is done. Okay, and give the appropriate counseling regarding the mode of subsequent delivery. Okay, delivery after anal sphincter injury. When contemplating delivery in a subsequent pregnancy, are the risk of recurrence of obstetric anal sphincter injury and the risk of developing anal incontinence. Okay, risk of recurrence of oasis. Most of the published studies are from centers practicing selective midline episiotomy, where the risk of oasis is around 11%. So if it is a midline episiotomy, the recurrence risk is high, 11%. While where there is a normal practice to perform selective medial lateral episiotomy, oasis risk is less, 4.4 to 6.8%. So it depends what type of episiotomy you practice, and that is how. So if you have a question, please read what information is given, whether they are asking after the midline episiotomy or whether they are asking after the mediolateral episiotomy. After mediolateral episiotomy, it is 4.4 to 6.8. So you need to note this down in your notebook. Okay. Risk of developing anal incontinence after subsequent vaginal delivery. The rate of anal incontinence was 56% compared with 34% in those who did not subsequently deliver. Okay, so anal incontinence will be higher. Okay, there is a study. These figures will not be as this study we can skip. Then there is another study who did a follow-up of 531 women 9 weeks after delivery and found that women with a grade 3C and 4 tears, that is third degree and fourth degree, here had significantly worse defecatory symptoms and bowel-related quality of life compared with women with 3 and 3B. So 3C and 4 will have a worst outcome as compared to 3 and 3B. So that finishes this talk article on obstetric anal sphincter injuries. Thank you.